My name, as you can see from the first slide, is Michael Niederman. I'm a pulmonary and critical care physician. I know Francis very well and happy to be here. And Dr. Kahn and Francis were both fellows at Winthrop when I was there. I was at Winthrop until relatively recently. And I would like to talk to you about community-acquired pneumonia, sepsis, and the role that biomarkers play in the management of these diseases. And what I'll present for you is a little bit of background about biomarkers and their role in managing infection. I'll tell you a little bit about how I got interested in this. I'll tell you about a study that we did at Winthrop to try to look at the utility of biomarkers and hopefully stimulate some discussion. So I actually didn't understand a lot about biomarkers and didn't have that much interest in it until about 7 or 8 years ago when I was asked by the FDA to come to a meeting where they were discussing trial design for clinical trials in pneumonia. And they asked me to talk about the topic of how could biomarkers be used to enhance trial design in pneumonia studies. And I will, at the very end, tell you what I told them, and I will tell you I thought I gave them good advice, and I'll also be happy to tell you that they didn't listen to any of the stuff I told them. So, but again, you're welcome to form your own opinion about what the role of biomarkers are in the treatment of infections. So I guess I need this one. See, how do I advance the slide here? Doing this one, nothing's happening. Okay, great. All right. So I've listed my disclosures here. We did have funding for our clinical study that I'm going to share with you. So I guess the first question that I wanted to open with is why is there a role for biomarkers and why not just use clinical parameters to assess patients when you're managing them with infection? And again, I think there's a couple of logical reasons to think that biomarkers could be useful. The clinical features that we use to assess patients while we're treating infection depend largely on the host response to that infection. That host response is going to change organism by organism, not only the organism identity, but the inoculum size. Prior therapy will have an impact. For example, if they've received an appropriate antibiotic therapy prior to your seeing them, some of the clinical manifestations may be less obvious. But probably most importantly, the clinical manifestations of infection are going to vary with the host. There are genetic polymorphisms in the immune response. Some people respond more exuberantly than others. Elderly individuals have less clear clinical signs of infection than younger people. And so the clinical features that we associate with infection may be less obvious in certain individuals, and the severity of illness itself may also affect the clinical presentation. A lot of the clinical features, as you know, that we rely on are not very specific for infection, and some of the clinical features give us information too late in the course to initiate timely therapy. We're all familiar, for example, in the case of dehydrated patients with pneumonia, where the infiltrates can be subtle. After we hydrate them, we can see the infiltrates much more clearly. So a number of inflammatory markers have been proposed as biomarkers to monitor patients during infection. There are the pro-inflammatory cytokines that are part of the pneumonia and sepsis pathogenesis, TNF-alpha, IL-1, IL-6, and these can also stimulate other acute phase reactants. They're the anti-inflammatory cytokines. The acute phase reactants, and the two that have been studied the most are C-reactive protein and procalcitonin, are the ones that have generally been proposed for clinical practice for monitoring patients with infection. About 10 years ago, there was a study in the New England Journal about STREM, which is part of the immunoglobulin superfamily. It looked like a very promising biomarker primarily because it was in the New England Journal, and nothing much ever came of that, and it's not something that anybody's thinking about using these days. And plasminogen activator inhibitor, one of the components of the coagulation cascade, has also been studied as an inflammatory biomarker. This is sort of typical of what you might read in the literature of C-reactive protein. This was a study done 10 years ago, looking at 200 patients with community-acquired pneumonia, some healthy controls, and patients with respiratory tract infections but no community-acquired pneumonia. And you can see that pneumococcal infection, C-reactive protein was higher, and if they had a negative microbiology, patients who were sicker and required admission had higher levels than those who went home. And again, this is the kind of information that's used. And if you read a lot of European guidelines, this is the biomarker that the Europeans prefer. It's cheap, it's widely available. It may not be as discriminating as other biomarkers, but it's a commonly used biomarker in many European hospitals. Procalcitonin is probably evolving to become a more important biomarker, certainly in some of the newer studies, and it requires a little bit of understanding, because certainly when I first heard about this, all I could remember from medical school is that procalcitonin had something to do with the thyroid, and I had no idea what that had to do with infection. But it turns out that procalcitonin is a hormokine, and it can be produced by a number of different cell lines. It can be produced by the thyroid and by monocytes, but the majority of the procalcitonin is produced by parenchymal tissues, particularly the liver and the kidney, in response to infection, and levels can rise 100,000 times above normal. Those rises occur extremely rapidly within 4 to 6 hours of the onset of infection, and that rise can last for up to a week after the infection is present. So you can imagine that it will detect infection relatively early, and the levels will stay high if you have an untreated infection, so that antibiotic therapy won't necessarily, 1 or 2 doses at least, won't necessarily mask the presence of infection as it might with some of the clinical manifestations. What I think is also important to understand is that it's upregulated by the presence of bacteria and downregulated by the presence of viruses. So with certain bacterial infections, the microbial toxins and the response to the microbial toxins upregulate the production of procalcitonin. And the differential effect of bacteria and viruses was exploited early on in the application of this tool, because, again, knowing that viruses were associated with cytokines that reduce procalcitonin production, a lot of the earlier studies were done in community respiratory infections where, in theory, you would want to use an antibiotic for a bacterial respiratory infection, not use an antibiotic for a viral respiratory infection. And with upregulation with bacteria and downregulation with viruses, it ought to have been very discriminating. The other thing to understand is that there are a couple of different assays for procalcitonin, but the commercially available assay that most hospitals are using now is the Cryptor assay, which is a highly sensitive assay based on a anti-calcitonin antibody. It can detect levels as low as 0.06 micrograms per liter, and a lot of the early studies on procalcitonin were done by a group from Switzerland, and all of their studies were done with the Cryptor assay. There were some studies that I'll show you that were done with the luminescent assay, which is a lot less sensitive and doesn't appear to be as valuable in clinical practice. So I think if you read about any of the studies of procalcitonin, you should pay attention to what assay was actually used in the studies that you're reading. But I would say that most of the current literature deals with the Cryptor assay, which is the one that's now most widely available commercially. So I've listed here some of the potential roles that you could use with a biomarker like procalcitonin in both community-acquired pneumonia and sepsis, and I'll try to share with you some of the studies that have explored these different applications. The first way that this was used is to define when to use antibiotics. It's also been used to determine how long to use antibiotics, how intensely to treat patients. In pneumonia, there's some very interesting studies that it can be used to define the site of care. It may define prognosis and infection. And then the last application might be, as I mentioned earlier, to define when to put a patient in a clinical trial. So the studies that have looked at the application of procalcitonin for when to use antibiotics have looked at distinguishing viral from atypical and bacterial infection. They've looked at acute exacerbations of chronic bronchitis on ventilators to try to decide when to use antibiotics. And they've looked at patients who had witnessed aspiration to try to determine could you separate those with chemical pneumonitis from those with bacterial pneumonitis, again, those who need antibiotics from those who don't need antibiotics. And so I'll show you some of the studies. The group from Switzerland has generally done most of their studies with this algorithm, and this is an algorithm worth at least being familiar with, that you measure procalcitonin in the serum. You can measure it when the patient's first admitted. In a lot of studies, it's measured serially throughout the hospital course. And generally, when the levels are extremely low, less than 0.1 micrograms, then the recommendation is no antibiotics. And if it's between 0.1 and 0.25, they generally recommend no antibiotics. Whereas if it's between 0.25 and 0.5, start thinking about using antibiotics, and above 0.5, definitely think about using antibiotics. But they definitely acknowledge that in either setting, you want to use your clinical judgment where you might frequently override what the recommendations are telling you. And I think this is extremely important, that if patients look sick, you would probably use antibiotics regardless. And the other caveat that I will tell you, again, when we're distinguishing the studies with sepsis and pneumonia, in pneumonia studies, there has been an effort to withhold antibiotics in people who don't look terribly ill and have low procalcitonin levels under the assumption that some of them might have viral infection and don't need antibiotics. I don't think anybody would recommend that in the setting of sepsis. So in the setting of sepsis, the application of procalcitonin is not to decide, do I or don't I start antibiotics? The application is to determine prognosis, and the application is to determine whether I can stop antibiotics shorter than I normally would. So it's very important to understand in these studies that the studies that look at do I or don't I use antibiotics are in settings where it may not be obvious that you need antibiotics, whereas the studies that look at how long you use antibiotics are more often in settings where you really have no choice to use antibiotics, but later on as you evaluate the patient, you're trying to determine could you possibly stop those antibiotics. So the first study that was done by the Swiss group, and all their studies have the acronym PRO in it, referring to procalcitonin. Their first study was the PRO-RESP study, and it was a cluster randomized prospective study of 250 or so patients with lower respiratory tract infections. They had community-acquired pneumonia. They had exacerbations of COPD. They had bronchitis and asthma. And they used that protocol that I showed you in about half the group. The other half got standard antibiotic therapy. And using that protocol, they determined whether to start antibiotics or not. And you can see in all of these diagnostic groups, in general, the procalcitonin-guided group got antibiotics less frequently than the control group. Very little difference in community-acquired pneumonia. But in the other diseases where arguably there's a lot more viral infection, they withheld a lot of antibiotic therapy, and they had a shorter duration of therapy, and the outcomes were similar. So they documented that this was a tool in this setting of minor lower respiratory tract infections and some community-acquired pneumonia. It was a tool to safely avoid overusing antibiotics. To me, I have to say, I read this literature, I didn't know what to make of it, but this study really sort of attracted my attention because if you look at this carefully, it's not the way most people would practice medicine. And this was the PRO-CAP study, and they took 300 patients with radiographic community-acquired pneumonia, and again did the same protocol where they measured procalcitonin on admission, then they repeated it 6 to 24 hours later if they had decided not to give antibiotics, and then at day 4, 6, and 8, and they used the procalcitonin guidance to decide whether to use antibiotics and how long to use antibiotics. But remember, every single one of these patients had radiographic pneumonia. So in clinical practice, I can't imagine there'd be anybody with a lung infiltrate that you would withhold antibiotics from. They had nearly 30% of the population had a low procalcitonin level, so potentially could have withheld antibiotics. And in half of that group, 15% overall, they actually decided to withhold antibiotics. So again, they didn't use it as an absolute rule, and half the people that had low levels, they still gave them antibiotics anyway based on their clinical assessment. But in the end, there were 15% of patients with radiographic pneumonia who never got antibiotics. And that, to me, was a startling number, because I couldn't imagine even 5% of the people that I see with lung infiltrates that I wouldn't give antibiotics to and would feel comfortable with that. But in 15% of the people with radiographic pneumonia, they withheld antibiotics. When they didn't measure procalcitonin, they withheld antibiotics in 1%, and the outcomes, as it turned out, were comparable in both groups. So they safely withheld antibiotics in 15% of people who probably didn't need it because they either had viral pneumonia or they had heart failure. They had some other explanation for their infiltrates, and they were comfortable not giving antibiotic therapy. More recently, people have started thinking about using this in ventilator-associated pneumonia. And I don't know if you're familiar with a tool called the Clinical Pulmonary Infection Score, but it's been touted as a tool to both diagnose pneumonia clinically and to follow patients with pneumonia serially. And the Clinical Pulmonary Infection Score includes fever, leukocytosis, oxygenation, radiographic patterns, oxygenation, and the quality and cultures of the respiratory secretions. And so there was a new proposal to modify that CPIS in what might be viewed as a more modern way, where instead of using white count, they used procalcitonin, and instead of using an X-ray for lung infiltrates, they used a lung echo. So this is sort of the modern clinical pulmonary infection score, and they found this to be more sensitive and specific than the clinical pulmonary infection score to predict ventilator-associated pneumonia in patients on ventilation and in those who were proven to have pneumonia. So it's a biomarker that's beginning to be used a little bit more widely and might have applications not only in community-acquired pneumonia, but maybe as well in ventilator-associated pneumonia. One of the questions has been, it seems clear that procalcitonin can tell you when there's a bacterial infection, and at low levels are present when there's a viral infection. What about atypical pathogens? And there, it's not perfect. It's good for identifying the atypical pathogens you don't need to treat, but maybe not 100%. So this is a study with the luminescent assay where they looked at procalcitonin in patients with atypical infection, mycoplasma, chlamydophila, and Legionella, and the assay was higher in bacterial infection than in atypical infections. C-reactive protein didn't appear to be quite as discriminating between bacterial and atypical pathogens, but this is with the luminescent assay. More recently, there was a study of 650 community-acquired pneumonia patients where they looked at all the pathogens that are shown here. They looked at C-reactive protein and procalcitonin, and if you look, for example, at atypical pathogens, the levels for mycoplasma and chlamydophila were quite low compared to pneumococcus. Again, not quite as discriminating with the C-reactive protein, but with Legionella, the levels were, again, not necessarily high enough to tell you that you would want to use antibiotics. The levels with Legionella were 0.7. The levels were much higher with bacterial infection. So it was not a perfect tool. It was definitely lower with viruses and atypicals. It was higher with Legionella than some of the other atypicals. So you probably would end up maybe withholding antibiotics with mycoplasma and chlamydophila, and you might not want to withhold antibiotics in that setting, and you would probably end up using antibiotics with Legionella. So I think this is one of the areas where you have to pay very close attention. You were asking before, with the low level, does that mean it's okay to not use antibiotics? And that's where judgment comes in. And this would be one of the reasons why a low level might have to be ignored, because it might still indicate an atypical pathogen infection. One of the other things I forgot to mention when I was talking about the biology of procalcitonin is it's eliminated from the body by the kidneys. So in the setting of renal failure, you can get falsely elevated levels of procalcitonin. So the way I look at using a biomarker like procalcitonin in renal failure is if the level is low, that's still extremely valuable information. You can't get a falsely low level other than with these atypical pathogens. But if the level's high, it may or may not mean anything. It may have meant an old infection. You just haven't completely eliminated all of the biomarker. Now, I thought this was an interesting potential application as well. What about the setting of influenza? We know that influenza can be complicated by bacterial superinfection, and so what if you have a patient with influenza? Could you measure a procalcitonin? Levels low, don't give antibiotics. Levels high, you know there might be a bacterial superinfection, you would use antibiotics. And as you can see in this relatively small study, the discrimination between pure H1N1 influenza and mixed infection wasn't perfect. And so, again, the way I would take this away is if you have an extremely low level of procalcitonin in the setting of influenza, it probably is safe to withhold antibiotics. But again, once the level begins to rise even a little bit, then the chance of mixed infection is enough that you probably want to use antibiotics in that setting. So it's not perfect in the setting of influenza. There's another more recent study of 46 patients in the ICU during the H1N1 season. And this included also those patients plus a meta-analysis. And again, they found that if you were looking better than C-reactive protein, there was less discrimination with C-reactive protein. With the level greater than 0.5, the sensitivity and negative predictive value for pneumonia was still pretty good. So again, I think the general interpretation here would be when the levels are elevated, you probably do need to use antibiotics, knowing that some of those people don't have bacterial superinfection. But when the levels are extremely low, it may be safe to withhold antibiotics in that setting. And this is another application that I thought was sort of interesting. This is a study that was done in Buffalo where they took 65 patients admitted to the ICU from the emergency department with a history of aspiration pneumonia. They did a bronchoalveolar lavage within 4 hours, and they classified these patients as BAL positive or BAL negative. Let me go back. And they classified them as BAL positive or BAL negative, and they looked at the procalcitonin levels, and as you can see, they were virtually identical. So it seemed like a really good idea that you could measure procalcitonin with aspiration, separate chemical pneumonitis from bacterial pneumonitis. Turned out it didn't work, and so I wrote an editorial that went with this paper to try to guess why it didn't work, and I think the answer may have been that all aspiration patients had so much inflammation present that they got elevated procalcitonin levels. Even if they didn't have a bacterial infection, there was a lot of inflammation, but a very high level turned out to be somewhat predictive of bacterial infection with certain pathogens, so it may have been an indication of a high enough level of inflammation to suggest that those patients were going to get secondary infection. But clinically, to manage patients, I don't think you can use it for that purpose. And then there was a study of about 100 patients with exacerbations of COPD who were treated on a ventilator in the ICU, and they were trying to look at the ability to, again, withhold antibiotics in this setting, even though, as you know, there's a controversy about whether you would use antibiotics in exacerbations of COPD. There's probably no controversy for an intubated ventilated patient with a COPD exacerbation. And they found if the procalcitonin was greater than 0.5 and the gram stain was positive, that was very highly predictive for the need for antibiotics. But conversely, if they didn't have a high level and the gram stain were negative, they were thinking it might be safe to withhold. I wouldn't make any of those judgments in a clinical context. I wouldn't make them absolutely based on any of the specific results. Now, the how long to treat and use antibiotics is a much more interesting question because there's no question that we use antibiotics much too long when we're treating patients with infections of all types. And so getting back to the ProCap study, as I mentioned, they had done procalcitonin levels on admission day 2, 4, and 6, and they were, or days 4, 6, and 8 rather, and they were trying to reduce the duration of antibiotic therapy. And they had some remarkable findings. They found that without biomarker guidance, they were treating patients much longer than with using serial measurements of procalcitonin. It applied to all severities of pneumonia. The only problem with these data is if you look at the y-axis on these studies, the duration of antibiotic therapy in the control group was about 13 days, which is, again, much longer than we'd probably use antibiotics today. Still, the duration of antibiotic therapy in the intervention group was about 6 days, which is still a very appropriately short duration of antibiotic therapy. And again, they demonstrated that they could use less antibiotics, shorter duration of antibiotics with biomarker guidance than without, and that was safe. The outcomes were the same in both groups. But a lot of people were not convinced by this, and they felt it was a single-center study, that more data was needed. So they then did the PRO-HOSP study, which was a multi-center trial in 6 Swiss hospitals. This was published about 5 years ago in JAMA. They looked at about 1,300 patients who came to the emergency department with lower respiratory tract infections. Same protocol, randomized to procalcitonin guidance or standard care. About 70% turned out to have community-acquired pneumonia. And you can see from the data here at every time point, the procalcitonin group is in dark, the control group is in the lighter bars. Every time point, patients were getting antibiotics with procalcitonin guidance. And again, they demonstrated that they could use less antibiotics. And generally, in some of these studies like this, less adverse effects from the antibiotics in the group that had biomarker guidance. So all of this is very positive. Use this serially in patients with community-acquired pneumonia and end up using less antibiotics. The first really big ICU study that included all comers with all types of infection was the PRO-RADA trial, and it was, in my mind, a real landmark study. They did a multi-center study with 600 ICU patients, infections of all types. 300, again, got the procalcitonin algorithm. The other 300 got antibiotics for 15 days for pneumonia due to Pseudomonas or other recommendations for other infections. And they showed, again, similar mortalities in both groups. But the procalcitonin patients had overall less antibiotic therapy, an absolute difference of about 3 days overall, that they were using 3 days less of antibiotics with biomarker guidance, and it was a particularly bigger difference, a more marked difference in community-acquired pneumonia and to some extent in ventilator-associated pneumonia. So all infections benefited from biomarker guidance, but even more so with pneumonia. But it appeared that it was possible to, again, measure this serially and use less antibiotics. And this is actually the day-by-day data in this study. How many of the patients at each time point were receiving antibiotic therapy. And you can see that at the beginning, virtually everybody got antibiotics. They actually did withhold some antibiotics in the procalcitonin group, but not very much. But very quickly in the first 10 days, the procalcitonin guided every single day they were stopping antibiotics in the control group. And in the end, as I said, it was almost a 3-day difference in the total usage of antibiotics in an ICU population of patients who had infections of all types. There have also been other more recent studies that have looked specifically at duration of therapy and sepsis. And this was a study done from Australia in 11 ICUs, 400 patients with suspected infection or sepsis, and they were expected to get antibiotic therapy for at least 24 hours. It was a prospective randomized study where they measured procalcitonin daily. And again, I will give you an editorial comment about this study design. I don't know if you've read the well-done prospective studies from this Australian multi-center group. They've done a number of them. They've done glucose studies. They've looking at insulin in the ICU. They've done pressor studies in the ICU. And I can guarantee you that every study they publish has the same result. It's a negative study. They show no difference in, it seems like they designed the trials to be negative. They're very much, in my opinion, a group that likes to say nothing matters. And that's the conclusion from this study. But I think that they reached that conclusion using very, I think, manipulated methodology. So first of all, there was a protocol-driven stopping of antibiotics, but you were only allowed to stop antibiotics if the procalcitonin was less than 0.1. As you saw, a lot of the other trials, they allowed it to be as high as 0.25 to stop antibiotics. And the predefined endpoint to be considered as a positive trial was there had to be a 25% reduction in antibiotic duration. You know, 1 day difference wasn't enough, a 2 day difference wasn't enough. It had to be a 25% reduction. So they randomized 400 patients. 93 in each group had septic shock, the others had sepsis, and there was a trend to fewer treatment days overall. It was 9 versus 11 with procalcitonin versus control, fewer treatment days in those with positive cultures, 11 versus 15, fewer treatment days with septic shock, but again, they weren't quite statistically significant. They did use less antibiotics with no difference in mortality, and they did demonstrate that the adjusted rate of fall in procalcitonin over the first 72 hours was a very useful predictor of mortality. Now, if you actually look at their data, if you look at the patients with sepsis compared to severe shock, at the beginning, patients with sepsis had lower levels of procalcitonin than those with severe shock. So they did demonstrate that in the setting of sepsis, the higher the level, the more severely ill the patient was. And you could see that the rate of decline was similar, although it started at a higher level with septic shock. And the procalcitonin decline over the first 72 hours was an extremely valuable predictor of both 90-day and in-hospital mortality. So on the surface, this was reported as a negative trial. You can decide whether you would have considered this negative. It did lead to some patients getting less antibiotics, and it certainly gave very useful prognostic information. Again, one of the things I didn't mention is that if you end up purchasing the machine to measure procalcitonin, the incremental cost for each test depends on your hospital, of course, is around $20 to $30. And if you have your hospital set up to do this as a priority, you can usually get the result within 2 to 3 hours. So when you look at the kind of data that comes from these trials, and you look at the cost that we're talking about and the potential benefit, again, you can decide if you think that that's too expensive for what information you're getting. But I know when we're treating patients with sepsis and septic shock, prognostic information is extremely valuable. And I think seeing this kind of information certainly allows you to talk with families and have better understanding about where things are going with your patient. Another more recent prospective observational study of procalcitonin was done in Ohio, where they didn't really have a protocol. They looked at 50 patients who had procalcitonin guidance for sepsis or pneumonia. Of those 50, 26 had sepsis, and they were all patients who were at least 72 hours in the ICU because of sepsis and pneumonia, and they collected the data prospectively. They compared them to historical controls. They didn't have a strict protocol for stopping antibiotics, and they included patients who got initial procalcitonin and at least one more repeat after 48 hours. And they found, again, when they compared their procalcitonin group to their historical controls, again, they found benefits that they found shorter duration of antibiotics, shorter stay in the ICU, less readmission. The C. diff infection rate was actually similar in both groups, but again, the readmission rates trended to be lower, and the relapses of infections were lower, and the 30-day readmission due to infection was significantly lower. So they considered this to be of some benefit, but again, it wasn't one of the prospectively done trials. To look at the randomized trials to study duration of antibiotic therapy, we wrote a review article about this a couple of years ago. Again, these are all the ones I've shown you, but in general, they all demonstrated that it was possible to use less antibiotics, no adverse mortality when you were using biomarker guidance. And to me, this is certainly a valuable benefit, and I don't think it comes at an exceedingly high acquisition cost for measuring the procalcitonin. The Swiss group also did an individual meta-analysis of over 4,000 patients with respiratory tract infections in trials looking at antibiotic duration. and I picked just the data from ventilator-associated pneumonia in this slide, but again, you can see at every time point, fewer patients with biomarker guidance are getting antibiotics than the control population. So we were very interested when I was at Winthrop to apply this, and I thought that the experience we had was very instructive of what happens in a hospital when you try to institute a protocol with procalcitonin. So before we did this study, I gave lectures to the entire medical staff, particularly to the house staff. We had a house staff team of fellows and residents that were very interested in the study. We had to do it with informed consent, so we had a little bit of a difficult time getting patients to agree to it. The protocol was we took 50 patients seen in the emergency department who had lung infiltrates where the decision had already been made to give antibiotics to. We weren't trying to withhold antibiotic therapy. And in our estimation, there are a lot of people who were coming to our ER with lung infiltrates and getting antibiotics who did not have pneumonia but had heart failure. And this was being done at a time when we were still doing the core measures for community-acquired pneumonia. Nobody wanted to miss giving antibiotics to somebody with pneumonia, and so we didn't want to tread on that ground. So we only enrolled patients where the decision had been made to give them antibiotics, and we were going to measure procalcitonin serially to try to stop antibiotics sooner. And in the end, what we found was that although we measured procalcitonin in both groups, we only gave the information to one group. The others, we let them do whatever they wanted. There were no difference in the procalcitonin levels between either of the groups, and there was a non-significant drop of about 20% in the duration of antibiotic therapy in the procalcitonin group from 5 days to 4 days. But what was interesting is, altogether, there were 17 patients who had a procalcitonin level less than 0.1 on day one. So a third of the patients had a low level of procalcitonin, potentially could have had antibiotics withheld. In the control groups, where they didn't even know the procalcitonin data, 10 patients had a procalcitonin level less than 0.1, and in 3 of those, they stopped the antibiotics. So without the procalcitonin, they were willing to stop the antibiotics. In the intervention group, there were 7 who had low levels, and we went by and we told them you could stop antibiotics, and they listened to us once. They continued it in 6 of the 7 patients. And so our conclusions were that when the information was told to the medical staff, there was a very modest effect on duration of antibiotic therapy, but a third of all patients in general had an opportunity to stop antibiotics on day one. That didn't happen that often. So I think there's no question that this kind of biomarker has the potential to reduce antibiotic use, but if doctors don't believe in it, they're not going to follow it, and it's a useless test to do. So what we found at that time is even though a third of these patients probably didn't need antibiotics and could have gotten away without antibiotics, they didn't listen very often, and they weren't willing to stop antibiotics. So the potential benefit was there, but if doctors won't listen, you will not get that benefit. I'm going to show you another study in a few minutes that corroborates the same findings, a much larger study, and I think that's really, for me, the question. If you're thinking about using it, you need to ask yourself is, do you believe the data enough that you're actually going to use it? Because if you measure it and don't believe it and don't use it, then it's probably not worth measuring. On the other hand, what happened at Winthrop after this study make it impossible to repeat this study now because for reasons that I don't really understand, the uptake of the procalcitonin is now universal, and would never convince anybody to manage a patient with infection without measuring procalcitonin every 10 minutes, it seems. I mean, now patients get probably 4 or 5 measurements during their hospital stay. So they've gone from one extreme to the other. I think we're not able to convince them to use it at all early on. Now they seem to be using it more than is necessary. And so I think you probably want to find a happy medium where you're measuring it appropriately and listening to it and not ignoring it and not overutilizing it. In terms of intensity of therapy, there was another interesting ICU trial which attempted to use procalcitonin in a way that it was never intended. It was a study of 1,200 ICU patients were, again, randomized to standard care or procalcitonin guidance. But here, they used procalcitonin in the opposite way. They used it as an alert level to escalate antibiotics. And if the procalcitonin level was greater than 1, and it hadn't decreased by at least 10% from the previous day, they gave more antibiotics and they did more diagnostic testing because they felt maybe this was an early warning sign that whatever they were doing was wrong and they needed to do something different. And what they found is not only was there no change in mortality, which is what this line shows, but they increased the length of stay and increased the rate of mechanical ventilation in the patients who had the intervention. So in other words, this warning sign turned out not to be a warning sign, and they actually overreacted and overtreated patients and arguably did some more harm rather than benefit when they tried to use it in a way that it was not intended for. Surviving Sepsis campaign did talk about procalcitonin. They said a high level could be used as an inflammatory marker to identify the presence of sepsis, and use of a biomarker could assist in the discontinuation of antibiotic therapy in patients who initially were septic, subsequently had no evidence of infection. And I think this is really a good summary of where it should be used in sepsis. I think probably even the first one may not be necessary. I think it still is a clinical judgment as to whether a patient has sepsis and whether you want to use antibiotics. And again, I don't think that the purpose of a biomarker in the setting of clinical sepsis is to withhold therapy, but the real benefit is to measure it serially. And a lot of people initially who you think are septic turn out to have other things. This may clue you in that it's just not necessary to continue the antibiotics. And as you saw from the pro-rata study and some of the others, even in the setting of ICU infection and sepsis, you can safely use less antibiotics with biomarker guidance. It may also, biomarkers in general may help you in the use of steroids in community-acquired pneumonia. This turns out now to be a continued hot topic. There have been a number of studies of steroids in severe community-acquired pneumonia. Some show benefit, some don't. This was a subgroup analysis of a negative study, but what they showed is that in the population that had high cytokine levels and low cortisol levels, there was clearly a benefit for using corticosteroids. In other words, if you had a patient with a lot of inflammation and not a lot of endogenous cortisol production, that might be a population that would benefit from corticosteroids. I was part of the multi-center study that was published in JAMA in February for steroids in severe community-acquired pneumonia. And in that study, we had a positive result of steroids with helping with the resolution of pneumonia. But what was unique about that study is, in addition to having severe pneumonia, everybody had to have a high inflammatory profile. So we only gave the steroids to people with high levels of inflammation. And I think that this is probably where I see the corticosteroids and sepsis and the pneumonia heading, is we probably will not be giving steroids to everybody with severe infections, but we may be doing some sort of biomarker profiling in patients with high levels of inflammation, may be the ones that we think about intervening with anti-inflammatory therapies. When we do use steroids, there's been some question is, does that attenuate the ability of serial measurements of procalcitonin? And there's not a lot of data on this, but here's a study of 20 community-acquired pneumonia patients, 10 with COPD on steroids, 10 without COPD, and not on steroids. And you can see that when you look at procalcitonin in the steroids in the control group, there was no attenuation of the initial procalcitonin level or the drop. And when you looked at C-reactive protein, it did seem to be attenuated a bit by the presence of corticosteroids. So again, in the steroid-treated patients with procalcitonin, the levels were not lower than control. In the C-reactive protein levels, they were lower than control all along. So it did not appear that the value of procalcitonin would be mitigated by the presence of corticosteroid therapy. Now, this is the ProReal study that I mentioned earlier. This was a study of what doctors really do with procalcitonin. And it was a prospective observational study of compliance with the procalcitonin algorithm in 1,400 patients. And it's a complicated design here. So what they did is they looked at a couple of different countries and a couple of different diagnoses. And what I'd like you to focus on is the light blue bars here. The light blue bars refer to patients who had procalcitonin levels less than 0.25. And the countries that they looked at here were Switzerland, France, and the United States. And the two sets of bars are, the first set is estimating how much antibiotics would have been used in these clinical settings, and the second bar is how many was actually used in the setting. And you can see that in Switzerland and France, when the procalcitonin levels were extremely low, they were using less antibiotics than predicted. In the United States, when the procalcitonin levels were low, they were actually using more antibiotics than predicted. In other words, in general, in the United States compared to Europe, doctors did not believe enough in the procalcitonin level to not give antibiotics even when the levels were low, which is exactly the kind of finding we had in our study. If you looked at it by diagnosis, the same thing. In bronchitis and in COPD, there was a decrement in the use of antibiotics. In community-acquired pneumonia, it had very little effect on the use of antibiotics. The observed and the expected use of antibiotics were virtually identical. So again, what this study showed was that people are more reluctant to listen to procalcitonin guidance in pneumonia than in other diagnoses, and definitely more reluctant to follow the guidance in the United States compared to the findings in France and in Switzerland. What about the site of care decision? This is a tough decision in community-acquired pneumonia. Do you put people in the hospital? Do you put them in the ICU? Well, it turns out there's some very interesting data of using biomarkers in the setting of community-acquired pneumonia and the decision to admit to the ICU. And I'll show you the data from the second study. This is a study of 1,600 patients with community-acquired pneumonia in Pittsburgh, and about 550 of them fell in the highest risk for mortality group, pneumonia severity indexes 4 and 5. These are the people who usually get considered for ICU admission. What they did is they measured procalcitonin in all of these 550 patients, and they divided the results into quartiles. There were 126 patients who had levels less than 0.1. So even though they fell in a population that had a high risk of mortality that traditionally would have been put in the ICU, out of those 126 patients, 2 of them died. And so if you look at the data in the PSI classes 4 and 5, in the lowest quartile of procalcitonin, there's virtually no mortality. So what you might say is if you're evaluating a patient who's borderline for ICU admission and the procalcitonin level is low, maybe it would be safe to not put that patient in the ICU. Conversely, if that patient is borderline and the procalcitonin level is high, probably is a very good idea to put them in the ICU. This was a study of patients with community-acquired pneumonia, about 10% overall admitted to the ICU, and they made the observation that many others have found that when you're really sick on admission and you go directly to the ICU, your mortality is lower than if you get sent to the floor, crash and burn, and then go to the ICU. People who don't look quite so sick don't need to go directly to the ICU, go to the floor, and then end up getting transferred to the ICU. Those patients have a higher mortality than those who are obviously sick and go right to the ICU. It seems counterintuitive, but what it's telling you is there's a price to pay for making a misassessment, sending someone to the floor and having them deteriorate. And when they looked at the procalcitonin levels, for the patients who were directly admitted to the ICU, their levels were extremely high compared to those directly admitted to the ward. But the people who had delayed transfer to the ICU actually had relatively high levels as well. And so, whereas a low level might tell you it's safe to go to the floor, a higher level, when you're thinking about sending them to the floor, might push you the other way. Maybe you actually want to put them in the ICU. What about prognosis? Again, these are 100 ICU patients with community-acquired pneumonia, measurements of procalcitonin on day 1 and day 3. And when you look at survivors, their levels are a little lower, died Initially, their levels are lower, but again, serially, their levels fall, whereas in the patients who died, their levels rise. So this may give you prognostic information measured serially. And similarly, in this study, looking at complications of pneumonia, meaning ICU admission or death, they measured procalcitonin serially. Patients who had complications had higher levels than those who didn't, and their levels fell much slower than patients who had no complications. So again, measured serially, it may give you some prognostic information. There's also, I think, some very interesting information about biomarkers, long-term mortality in pneumonia. You may not be familiar with literature, but turns out that in community-acquired pneumonia, there are more people who end up dying at 6 months than end up dying in the end of the first month. Nobody's quite understood what this long-term mortality community-acquired pneumonia is all about. This study looked at a number of biomarkers to predict 180-day mortality, and it turned out that cardiac biomarkers were a better predictor of 180-day mortality than inflammatory biomarkers, which is a really interesting observation because of studies like this, that now people are recognizing that pneumonia may be a precipitating event for acute myocardial infarction and other cardiac events. And the pathogenetic sequence is that patients who have pneumonia have increased oxygen demand, thrombogenesis, hypotension. All of this can lead to myocardial suppression, rupture of vulnerable plaque, and lead to arrhythmias and infarction. And in the two studies listed here, community-acquired pneumonia was complicated by myocardial infarction in about 6 to 7% of patients. So biomarkers may be also giving us clues as to some of the long-term consequences of infection. The last thing I told you I'd mention is how we might use a biomarker to decide who to put in a clinical trial. So as I told you, I was invited by the FDA to talk about this issue. We wrote this up. Our recommendations were published. But what we recommended to them is that if you're doing a clinical trial, patients with radiographic pneumonia, and you're trying to test a new antibiotic, you would probably not want to give antibiotics or enter a patient in a trial in anybody who had a low procalcitonin level. Because if I used the greatest new antibiotic in the world, or if I used sugar water, I would get comparable results to my best antibiotic currently approved if I tested people who've never had infection to begin with. And so we thought it was not a good idea to enroll patients in trials when they had low procalcitonin levels. And similarly, we thought that you might be able to use levels measured serially as a surrogate marker in superiority trials. And although I still think those were reasonable recommendations, as I told you in the beginning, the FDA decided not to incorporate any of that in their trial design recommendations. So to summarize, and this is taken again from our review article a couple of years ago, there are advantages and disadvantages to using biomarkers to manage infection. The advantages are that they provide information that's specific to infection and the need for antibiotic therapy. As we discussed, the levels can be high with bacterial infection and not in viral infection. Levels rise very rapidly with bacterial infection, and the response is generally not organism dependent, and it may be more specific for bacterial infection than you're going to get with a clinical assessment. They get results rapidly, early in the course of illness, and it can help you define prognosis. It may supplement the information scoring tools, and it may help you determine how long to continue antibiotic therapy. The disadvantages are that sometimes the results will be misleading. It may conflict with your clinical assessment. Levels can fall rapidly with the right antibiotic therapy, so if you waited several days, you might get a false negative result. If you only had one dose of antibiotics, probably it wouldn't matter. Again, atypical pathogens may not always be recognized with high levels, and with influenza and with aspiration pneumonia, it's not absolutely discriminating between when you do and don't need to use antibiotics. But I think this field is evolving, and I think the information is very interesting. So I've tried to share with you a lot of the current data about biomarkers. Many of the studies have been done in pneumonia, more so than in sepsis, but again, the ProRata trial is a large ICU-based, all infections, sepsis included. A couple of other studies I showed you deal with sepsis as well. And I think there's certainly the potential to utilize this in a number of settings. I find it valuable primarily with sick patients to shorten the duration of antibiotic therapy and to give me prognostic information. I thank you for the chance to speak to you today and be happy to answer any questions. Thank you. Francis, I knew you would have the first question. That's good.
Didn't want to disappoint you.
Absolutely.
So in your patients who group with infiltrate septic very sick early, but either low levels or negative, is there a minimum duration of antibiotics that you like to use?
Yeah, I think, practically speaking, I would use 3 days of antibiotics. If they're really sick, but I'm going to look at them every day. Sometimes those patients early on declare themselves to have something else. But I think that where it's valuable in that setting, it's not so much that I would withhold the antibiotics, but I would feel a lot less comfortable about using antibiotics and thinking I know what's going on if the levels are low. So I think that that's the difference. I think, if I see somebody with pneumonia, lung infiltrate, procalcitonin levels 10, I stop worrying about whether I have the right diagnosis and start wondering how they're responding, making sure I'm targeting the right pathogen. If that same patient had a procalcitonin level of 0.1, I might still use antibiotics, but I'd be very worried that I'm missing something and start thinking more carefully about alternative diagnoses. Is there another question? Yeah.
Given, the potential value in terms of prognosis, do you have in your hospital or do you have recommendation regarding, setting up a critical value that the lab should call the physician for?
No, again, I don't. No, we don't, and I don't think people do that for a couple of reasons. Because, as I said, I think you can have a serious infection with a low level, and that past study that tried to do that idea of an alert value, telling you that when the level's really high, you've got to do something different. They couldn't prove that. So I think that a single value, probably not. I think when you look at the prognostic value of this, the prognostic value comes serially with the exception of that site of care decision. But again, I think that that's going to be weighed in with a lot of other clinical factors. So I would, if I'm trying to determine prognosis, I like serial measurements more than a single value, except, as I was saying, with pneumonia, if you see somebody that you're not sure what to do with, a single value might help push you one way or another.
That's what I was thinking of, because we see that uncommon immunization in the ED, which could have been better served if they had a value that's elevated, recognized, to come to the ICU versus the...
Right, and I think that kind of situation, like I said, I think there's some data to show that in pneumonia. For all forms of sepsis, less data. But I think and I think that if you're using it to determine site of care, that might be a reasonable way to do it. I think, as you saw with the past study, for using it to escalate antibiotic therapy, then I don't think there's as strong a data for that. Yeah.
Do you use CRP anymore, or is this basically...
The CRP, you mean? No, I don't use CRP. As I mentioned, it's used a lot in Europe. It is a little bit more widely available, but I haven't seen a lot of data to show that it's as good as procalcitonin. It seems like procalcitonin is more discriminatory. SED rate is just so nonspecific that I can't see using it for these kinds of purposes. Other questions? Yes. You had a question over there?
Well, it's going back to your slide regarding the different countries that have looked at this, and especially with the duration of antibiotic use. It seems like the U.S. culture is, regarding everything, more is better. And I just wondered, changing physician behavior, I think, is like herding sheep or cats, and it just doesn't work too well. But do you think that as this data gets a little bit more refined, that people are going to be more accepting of this, particularly in light of antibiotic overuse nowadays?
Yeah, I sure hope so. I think there's certainly an interest in antimicrobial stewardship now that didn't exist 10 years ago. So I think that's possible, but I agree with you. It's hard to get physician behavior to change, and I was disappointed by what happened in our hospital initially, and like I said, it seemed very similar to that ProReal study. So I think that, you know, what I have seen since then is that there are people who use this, believe in it, apply it, and I think if you're a believer and you're using it, I think that's fine. And I think when you get good results and you continue to use it and you discuss it with your colleagues, I think gradually it will take on a life of its own, which is what we saw at Winthrop after we did that study initially. So I think I wish the answer were just give more lectures and educate people and they'll do the right thing. I don't think that's the case, at least not any of the studies support that. But I do think that if you have champions and advocates who use it and believe in it and make it part of their practice and over time talk about it with their colleagues, I think that's how it catches on.
And just a quick follow-up, I'm sorry, but you know, you mentioned that in your hospital, your staff is utilizing this a lot more. Are their behaviors changing?
Yeah, yeah, and I'll tell you a very common behavior that where I find it useful is as a consultant, we'll come and see patients with a lung infiltrate where they want to know, should they be using antibiotics? Is this pneumonia? And I'll say, my clinical assessment is no, you don't need to use antibiotics. If I give that recommendation, sometimes they listen, sometimes they don't. If I give that recommendation and say, and the procalcitonin level is less than 0.1, and that corroborates my recommendation that you not use antibiotics, people are much more willing to listen with a lab test. So I think that's where it can be very helpful. Yeah.
Any data on immunocompromised and neutropenic patients?
Yeah, I mean, again, it generally works when the levels are high in that setting. I think you've got to be some suppressed patients that the levels are low. So I think you have to understand every clinical situation is unique. So an immune-suppressed patient can't, for any reason I can think of, have a falsely low level. And in general, it's a reliable test, even in an immunosuppressed patient, because it doesn't depend on the white cells for production. This is a liver-produced acute phase reactant. So it really should not be suppressed in an immune-compromised patient. It should still have value. Again, my only hesitation, as you know, is with a severely immune-compromised patient, becomes a very difficult proposition to withhold antibiotics when you think they're sick. So I think you've always got to look at these tests in the clinical context. There's no absolute numbers. You know, it'd be nice if medicine could be a bunch of rules that you could follow and never be wrong, but that ain't the way it is. So this is